Southwest Connecticut, the local NAMI affiliate serving Lower Fairfield County. We're a nonprofit member organization dedicated to improving the quality of life for individuals and families living with a mental health condition. NAMI offers 12 free and confidential support groups every month. There are two types. There's family support groups, which are for friends and family of adults with a mental health condition, and NAMI Can for parents and caregivers of children and adolescents. We also offer free evidence-based classes. There is Family to Family, which is an educational program for family and friends of adults with a mental health conditions, and NAMI Basics for families of children. We have this speaker series and a book club that meets every other month on Zoom. By the way, our next book is Eve's Apple by Jonathan Rosen, and they'll meet on May 20th. You can find the registration on our website. And as I mentioned, as I went through that, but to emphasize, there's never a fee for any of our events or support groups or educational offerings. So I encourage you to visit the website at NAMISouthwestConnecticut.org. That's NAMI Southwest CT.org. And I encourage you to become a member of NAMI. Thank you. Now, let me introduce our speakers, Doctors Ostroff and Majoka. Robert Ostroff is a clinical professor of psychiatry at Yale University, medical director of the Mood Disorders Unit at Yale University School of Medicine, Yale Psychiatric Hospital, and the co-medical director of interventional psychiatry at Yale Psychiatric Hospital. Muniza Majoka is an assistant professor of psychiatry at Yale University School of Medicine and an active member of the interventional psychiatry team at Greenwich Hospital. Please remember this presentation is not providing individual medical health care advice. If you find it helpful, please share the information you learned tonight with your clinical team to confirm that these tools will be helpful for your loved one. And with that, I would like to turn it over to our speakers.
Is you putting the slides up?
Can you see the slides?
No.
Okay. On my end, it shows that I am sharing screen.
Yeah,
I'll try
I can
again.
see them. Yeah, try it again.
Okay. Can you see them?
No, I have two screens. Oh, I'm sorry. You're on. It's on the other screen. I got them.
Okay. All set.
And you're gonna control them, right?
Yep.
So I'm gonna start this talk. Muniza and I are gonna share it. Muniza is in charge of developing the interventional psychiatry service at Greenwich Hospital. I've developed the interventional service at Yale New Haven Hospital starting in 2013. So we have about 11 years experience there with interventional psychiatry. And I'm going to talk about an overview of interventional psychiatry first and why it's important and what it is. And then Muniza is going to talk about some specific modalities. So we can go to the next slide, Muniza, that's fine. So what is interventional psychiatry? So let's define it. Originally, it was talked about as a subspecialty of general psychiatry that uses neuro-technologies to identify dysfunctional brain circuitry underlying psychiatric disorders and using brain stimulation techniques to modulate that circuitry. We expanded the idea of neuromodulation to include novel psychopharmacology, novel psychopharmacologic interventions and novel means of delivering psychopharmacologic interventions. And you'll see when we get to ketamine that we're doing both intravenous and intranasal administration of the drug. So primarily, we need interventional psychiatry because we've not been doing as good a job as we would like to do in treating people with serious psychiatric disorders. And it's become an emerging subspecialty that treats patients with disorders that are resistant to routine measures by employing advanced treatment modalities and procedures. Interventional psychiatry requires expertise beyond the training that's provided in a typical general psychiatric residency, that it requires advanced technical, psychiatric, and general medical training and expertise to be able to provide these treatments in a safe and effective manner. At Yale New Haven, currently, we're focused on the unfortunate term treatment-resistant depression. I prefer difficult-to-treat depression, bipolar depression, refractory schizophreniform disorders, catatonia, and OCD. And we'll talk about these a little bit later in the lecture. So the brain is a complex electrical chemical network. So this is a screenshot of what the synapse looks like. There's all kinds of activity going on in the synapse, and what often gets forgotten is there is all this chemical activity that we've been focused on for the past 50 years, and have suddenly in the last decade appreciated that the whole point of the activity is to create an electric current and carry information to other parts of the brain or body. So the upper left-hand corner is the lateral part of the frontal lobe, which is a target for transcranial magnetic stimulation. The entire central nervous system, the brain, is a target for electroconvulsive therapy, and ketamine, the target, is trying to affect the synapse in a way that has a therapeutic effect, particularly for depressive disorders. So the interventional treatments we talk about are transcranial current stimulation, which is a very low-level current administered to improve attention, concentration. It's big with gamers who can make their own device, and there's also a device on the athletic market for improving learning of athletic skills. Repetitive transcranial magnetic stimulation is using a magnet that can cross the skull into the brain and stimulate it and either increase activity or decrease activity. Electroconvulsive therapy is surprisingly not the most invasive treatment we have. It's invasive in the sense that it requires general anesthesia, which is quite short. We'll talk about that more in a few minutes, but nevertheless, it requires general anesthesia and it's usually administered over the course of 3 or 4 weeks. Vagal nerve stimulation, which is the implantation of a battery in the left chest wall that is then implanted around the vagal nerve in the neck, and it administers a low-grade electrical current on and off to the vagus nerve, and it's used for both treatment refractory epilepsy and more recently difficult to treat depression. And then finally, deep brain stimulation, which is implanting electrodes into the central nervous system, into the brain, targeting certain areas. It's been most successful in the treatment of Parkinson's disease. And I think the jury is still out whether it's useful for conditions such as depression, Tourette syndrome, and OCD. But it has been very effective in the treatment of severe Parkinson's. Pharmacologically, we use ketamine both intranasally and intravenously. We have clinical trials going on of a different degree There are neurosteroids now on the market that are administered both IV and orally. Brexanolone is on the market now for the treatment of postpartum depression. We're involved in clinical trials of psilocybin for depression, DMT for depression, and MDMA for post-traumatic stress disorder. There's also the use of Botox intramuscularly to treat depression, which we're not involved in those clinical trials. The treatments that we're doing currently at Yale New Haven are electroconvulsive therapy. It's been in use for over 70 years. It's been grandfathered in as an effective treatment. It's indicated according to the FDA for major depressive disorder, bipolar disorder, and catatonia. They feel there's not enough significant evidence to authorize it for schizophrenia or schizoaffective disorder, even though some of us would beg to differ in terms of the evidence. Transcranial magnetic stimulation was first developed in 1985. It's a use of a magnet primarily on different locations in the skull to deliver a current that changes the nature of the signals in the brain. It's used as an acute treatment for treatment-resistant depression. There are multiple devices on the market. It's also been approved for OCD, and there are 2 devices on the market that have the magnet that's used to treat obsessive compulsive disorder. And more recently, one device got the approval for smoking cessation using transcranial magnetic stimulation, and it's widely used in Europe for all 3 conditions. At Yale New Haven, we use TMS for MDD, major depressive disorder, and for OCD. And finally, ketamine, it has been significantly developed at Yale University and Yale New Haven. The first studies were published 25 years ago. It was originally used as an anesthetic in the 1960s. It has properties that have a pain relieving effect. S-ketamine is one of the 2 enantiomers. Each molecule has a left and a right side. S-ketamine is the left side, and the FDA approved this in March of 2019 based on, in large part, studies we did at Yale New Haven. And S-ketamine is approved for augmentation of oral antidepressants. So you have to be on an antidepressant that's not working for treatment-resistant depression. It's also approved for depression with suicidal ideation, where you do not have to be on an oral antidepressant at the time of treatment. Racemic ketamine treatments, racemic, I mean intravenous, is what's widely used in the community. And what we started with 10 years ago are IV treatments. And they've been used to treat, again, difficult to treat depression, bipolar depression. There are also studies using it to treat post-traumatic stress disorder and also chronic pain syndrome and chronic regional pain syndrome. And if people are familiar with pain treatments, intravenous ketamine is frequently used in the pain pumps to augment and reduce the need for opiates because of its analgesic effect. Next. So how good are we at managing psychiatric disorders? Not very good. If you look at the 10 leading diseases that are contributing to global years lived in disability, mental and behavioral disorders, unfortunately, lead the way. Much smaller component with neurological disorders. And the leading cause of disability in the United States is depression. Next. So I'm going to tell you probably more than you want to know about each of these treatments. Muniza and I'll share the, I guess the screen, not the podium. Electroconvulsive therapy is one of the most effective treatments we have in psychiatry. It's also the most burdened. These are the picture on the left was from an illustration of a magazine article that I was interviewed for that was going to give a non-biased view of the use of electroconvulsive therapy. On the right is Jack Nicholson getting electroconvulsive therapy without anesthesia in One Flew Over the Cuckoo's Nest, which is probably the most common reference to ECT that I hear about. Next. So some things have been done to correct the perception about ECT. This is Kitty Dukakis, who was the wife of Michael Dukakis, an unsuccessful presidential candidate who got ECT after he had lost the election, got profoundly depressed, responded to ECT, and she talks about how it saved her life and has been unfortunately, she passed away about 6 months ago. She and her husband have been leading proponents of both the use of electroconvulsive therapy, but the recognition of how serious depression can be. And they held their own support group up in Boston for years that was open to the public. Next. This is Sherwin Newland, who was a Pulitzer Prize. He's a surgeon, Pulitzer Prize winning author who gives a great TED Talk overview of ECT. Was a friend of our service and big supporter. This is on our website, but he talks about how ECT changed his life and that he was lucky to have it and had it twice, once in his 40s and again in his mid 60s. Next. So if we think about treatment refractory depression, difficult to treat depression, the question is how well do we do with ECT? The remitters are on the remitters are in the blue, and this is a combination of the number of people who drop out of treatment, the number of non-remitters in the treatment. Remitters are considered people who are actually completely well and don't have detectable symptoms of depression. And it's around 62% with ECT. The responders are people who still have symptoms but have had at least 50% reduction in their overall symptoms. So you can see and this is treatment-resistant depression. We don't have a great definition of this, but it's basically people who failed at least 2 antidepressants in their course of treatment for depression. Next slide. So the reason electroconvulsive therapy is the gold standard for treatment-resistant depression, if we define treatment of depression as people who have failed at least 2 antidepressants, and we pick any antidepressant for the third drug, the response rate is about 13 or 14%. So you can see the response rates with ECT are 60 to 80%. Remission rates are 50 to 70%. It shouldn't be the option of last resort. I tell people there are too many options. Nobody's had them all. And if you fail ECT, there's still other things that we can do and we may do. They may serve you well. So it's not the treatment of last resort, but it often is treated as if there's nothing else left. We recommend at least a discussion of ECT after the first or second failed antidepressant trial if there's poor functioning at work, relationships, clearly for suicidal ideation, and for people with any kind of delusional rumination, like feeling that they're impoverished, they don't have any money, their health is suffering, they're going to die soon, even though they're perfectly healthy by any other measures, are people who do very well with ECT treatment. Cognitive side effects still exist, but they're much less than previous modalities of ECT. The machine has changed dramatically in the last 70 years. Next slide. So there's no age cutoff. Adolescents through geriatric patients are appropriate for treatment. It's important that there are no absolute contraindications to ECT. There are things that we take seriously, particularly if there's central nervous system conditions or other central nervous system conditions or cardiac conditions, and we take each case as an individual case and try to weigh the potential benefits versus the risk. It's safe during pregnancy. It's probably as safe, if not safer, than medication, and certainly works better. Again, the relative risks for ECT or cardiac conditions, arrhythmias, coronary vascular disease, neurologic disorders, things in the central nervous system that may be at risk, and implanted intracranial devices, the size, location, material of the object all makes a difference in terms of the risk of ECT. Next slide. You want to take over for ketamine, Muniza?
Yeah, sure. Thank you, Dr. Ostroff. So, well, let's talk a bit about ketamine. What is ketamine? It was initially approved in the 1970 for use as a general anesthetic and an analgesic, and is commonly being used in medicine, both for the human populations as well as for the veterinary populations. It is a dissociative and psychotomimetic agent. What that basically means is that it can create these states of dissociation, which can be variable for different patients or folks who use ketamine. It could feel as if you are a bit disconnected from your body, you're a bit floaty. Some people have some interesting thoughts during these times. Some people feel as if they can't move parts of their body during the experience. These effects, again, are variable between different people, but also between different experiences of the same medication. And is something that we'll talk a bit about a bit later on. But how does it basically work? So the effect of ketamine, specifically when we talk about depression, is pretty complex. One of the simplest ways to think about it is that it has an impact on a specific form of receptor called the NMDA receptor. That receptor specifically is involved in the transmission of one of the neurotransmitters or chemicals in our brain called glutamate. Glutamate is an excitatory neurotransmitter. When ketamine blocks this particular receptor, it leads to this glutamatergic surge or an increased level of glutamate in specific areas in the brain that are associated with depression, and therein lies its effect on depression. That's just one aspect of its action. It also further leads to expression of several proteins in our brain, which we call neuromodulatory proteins. Ultimately, what that leads to is a state of neuroplasticity. Neuroplasticity is a way to think about how your brain can create new connections, enhance the strength of certain connections, and these connections can be very helpful in particular treatment of depression. As Dr. Ostroff mentioned earlier, we do provide both intravenous ketamine and also the intranasal ketamine. The intravenous ketamine is what we refer to as racemic ketamine, which is the chemical with both of its enantiomers. Enantiomers are basically the forms in which a molecule can exist in nature. They're both mirror images of each other, and with certain development, what we found is that the S enantiomer is potentially more potent and was thus placed into an intranasal form, which was recently FDA approved in 2019 specifically for the depression treatment, or for the treatment of difficult depression. Here's where it all started. In early 2000s, late 1990s, there were these reports of ketamine's rapid effect on depression. There were studies done with just one treatment of depression, and this is a seminal paper by Berman, and that basically summarizes everything in these lines. To the amazement of our patients and ourselves, we found that ketamine produced rapid, profound, and surprisingly durable antidepressant effects that were temporally dissociated from the brief acute behavioral effects of the drug. And so this was the impact of just one treatment of ketamine. Over time, we have progressed significantly, and what we have come to now is from that single infusion protocol, we have moved to multiple infusion protocols. And those have been very helpful in helping a lot more people. As we'll talk about the response rates, they can be very variable and occur during different times of treatment. And as Dr. Ostroff mentioned earlier, we are providing both of these treatments, both the infusions as well as the intranasal insufflations, and we have had great success. So how does it happen, or the whole process of ketamine? We get an initial consult for a patient who has had difficult to treat depression. Once we are certain that they've tried multiple medications that will qualify them for the treatment-resistant depression definition, we then have them do a pre-treatment medical workup because there are certain impacts on blood pressure, heart rate that are important, and we need them to be addressed before we start treatment. And of course, review the consent process for the patients. The initial treatments with ketamine, whether it's intravenous or intranasal S-ketamine, it's done twice a week for a total of 4 weeks. And that means there's about 8 total treatments. If there is a response positively to these treatments, we then spread them to another 4 week of optimization treatments for patients come in every week for the treatment. And from there on, we try to spread the treatments as much as possible, while also maintaining the benefits of the ketamine. Again, Dr. Ostroff did allude to this earlier as well, but being on an oral antidepressant is also very important during the times of ketamine treatment because it's shown to enhance the times of, or enhance the maintenance of the positive benefits that you might have had during ketamine. So this is just how the intranasal form is given. The intranasal form, again, is the FDA approved as ketamine, which is thought to be more potent than the R-ketamine enantiomer. You can think of it, this insufflation device, as kind of like an inhaler, but you use it through your nose. Take a deep sniff, it gets absorbed through your nose and your upper throat, and you start to have some of the effects of the treatment. What are the effects of the treatment? Once you have the medication in your blood system or in your blood, basically it's going to go directly to a lot of the neuronal systems. That will lead to a feeling of dissociation, which I just described earlier. That's going to last for about 40 minutes or so. During this time, the ketamine is also going to affect blood pressure, leading to an increase in blood pressure and increase in heart rate. There's also possibility some side effects, like potentially some nausea, some vomiting, or some headaches. Those are all very easily manageable. One of the contraindications, which is an absolute contraindication specifically for S-ketamine according to the label, is that we cannot use it for patients who have an aneurysm of any kind, because an increase in blood pressure could lead to a possible risk of any of those aneurysms rupturing potentially. There is a possibility of abuse or misuse of the medication, and it is a drug that is used in different settings to excess. And a lot of the data that we have about the adverse effects, especially for the long-term use, comes from studies that were done in patients who were abusing ketamine. It's a common drug of abuse in East Asia, not as common in the US at this time. But really quickly, what can happen in those situations is that there can be inflammation of the bladder, or there can be some cognitive impairment. Because of the risk for abuse and misuse, at the time of the FDA approval for S-ketamine, a risk evaluation and management strategies form was implemented. This is basically a drug safety program that the FDA requires for certain medications with serious safety concerns to ensure that they are delivered to the population in the most controlled way possible and minimize any potential for diversion or any other issues. So for S-ketamine, we have to register all of our patients into this central registry and also follow up with any issues that might have happened during their treatments. The other examples in psychiatry where we have a REMS program is clozapine, most importantly. So in short, it's a treatment that is available, mostly covered by insurances, particularly in the S-ketamine form, that can be very helpful for depression, specifically treatment-resistant depression or depression where you have suicidal thoughts that are intrusive and troublesome. The response can happen at any time. Some people respond early on in those treatment of 4 weeks, and some patients later on in treatment. Really quickly moving on, the other modality we wanted to talk about was transcranial magnetic stimulation, or TMS. So basically, what is TMS? Dr. Ostroff already alluded to this as well. This is a modality which is, of all the modalities that we do have available, the least invasive, and it's effective in a very specific, focally directed mechanism. As you can see, there is an H-shaped coil on top of the person's head. That's the coil through which electricity is coursing at different times. That electricity then generates a magnetic field, which penetrates through the skull into the different brain tissues or areas that we're targeting. The very specific area that we target for the depression component is on the left side of the outer frontal lobe area. That basically is an area that has been shown to be less active during times of depression, and specific activation or use of this magnetic field leads to increased activity of that area. That increased activity ultimately leads to an improvement in depression. So again, how this magnetic field does that is dependent on multiple different forms of the way that this treatment is done. If we have the magnetic pulses or the electric current pass through the conductor very quickly, we have magnetic fields created at a very high frequency, and that frequency then activates the neurons. If you do it at a lower frequency, it inhibits the neurons. So based on the indication of whether we want increased activity of neurons in a specific area or decreased activity of neurons in a specific area, we have quite a bit of range in terms of the way that we can use this treatment. Ultimately, what happens is that with the use of the magnetic field and the increased activation, neurons are more likely to form, again, enhanced neuroplasticity and make new connections, make more solid connections, and that ultimately is what leads to alleviation of depression. 2 of the FDA approved indications for treatment, specifically for psychiatry, are major depressive disorder and also obsessive compulsive disorder. So far, we don't have any further approvals for use in other psychiatric indications, but again, there is a lot of work being done in this field. So how often do people respond to TMS? For depression, response rates can be anywhere between 30 to 40%, and people who actually have complete resolution of their depression can be anywhere between 15 to 30%. There's also behavioral activation, and there is recommendation the use of therapy during this time also leads to enhanced effect. This again is related to the brain's neuroplastic state, where it is able to make new and stronger connections, and the use of therapy can ultimately lead to improved outcomes as well. We do also require patients to continue on their antidepressants as well, because that's when we also have the best outcomes. As I mentioned, this is the least invasive of all of our interventional modalities. It also comes with the least risk. The more common side effects could be potentially headache or neck pain or even irritation at the stimulation site. These are all treatable and without any major issues. The most rare but significant side effect that we are very cognizant of is the potential for a seizure. Again, the possibility of that happening is very low. I just wanted to kind of bring this up just for education, or like just to kind of share what is happening. As you mentioned, the resolution of or complete resolution of depressive symptoms can occur in about 15 to 30% of the patients who undergo traditional TMS, as it's available in most places. There is a lot of work that's being done within this area to enhance its effectiveness, and there is a new form of TMS, which is using different types of frequencies of the magnetic stimulation, leading to much higher response and remission rates. This is currently not FDA approved, but it is really on the way to changing the way the TMS is being done and making it much more potent over time. I really quickly wanted to review some of the other upcoming interventions as well. Again, some of them we briefly mentioned earlier. One of them is transcranial direct current stimulation. This is basically using electrical current through application of two metallic electrodes on the scalp. They use a very small amount of electricity to again lead to specific focal activation of certain areas of the brain. These can then be ultimately lead to some change in depression, particularly, as well as other forms or other medical issues as well. Vagal nerve stimulation is, as you can see here, another form of interventional psychiatric modality, which is a bit more invasive. It requires surgery to place these electrodes along the vagus nerve. The vagus nerve is one of the biggest nerves that runs from our brain to different parts of our body and controls various functions. The interesting part about this nerve is that it has direct connections between two specific areas, which are the biggest areas producing two neurotransmitters. One is noradrenaline and the other is serotonin, you might have heard of. The idea about vagus nerve stimulation is that the use of these electrodes leads to ultimately increased stimulation and increased production of these two neurotransmitters, leading to an improvement in depression. Deep brain stimulation is another form, which also, of course, requires surgical implantation. As you can see on the right-hand side, there are metallic probes that are placed into a specific part of the brain. These then lead to activation or even inhibition of certain areas of the brain, ultimately leading to specific impact. In terms of psychiatry, obsessive compulsive disorder, it is an area that does have FDA approval for the use of deep brain stimulation, but still has a long way to go. As Dr. Ostroff mentioned, the most successful treatment with DBS so far has been with Parkinson's disease. Also wanted to quickly bring up what we're going to be having in the future, both short and long-term future, and that's the use of psychedelics for improvement or response to different psychiatric concerns. MDMA is a commonly known substance that is currently in process of being reviewed by the FDA for use in terms of its effect on PTSD. And there is a possibility that it would be in practice and use in the next year or two. It has shown a lot of promise. Again, it's specifically for PTSD. The way that all of these psychedelic treatments are currently being done is that they are associated with the use of ongoing psychotherapy during the time of treatment, or some form of therapy during the time of treatment, along with sessions before and after the treatment to provide education, but also consolidate and process all the information, feelings, and everything else that comes up during these times of use of psychedelics. The other psychedelics that are being currently studied, not limited to, but most importantly, including DMT or dimethyltryptamine and psilocybin. These are also both compounds that are being used similarly, with projected possibility of going up to the FDA in the next few years. So what are the indications for different interventional treatments? I'm sure a lot of us are aware of major depressive disorder, which is basically these times when we feel really sad without any clear external cause, where there is a lack of interest in the person's usual interest. There might be changes in sleep, either increase or decrease, and the same with appetite, either increase or decrease in appetite. There is a lot of fatigue, and then there's also difficulty with concentration, motivation, and there could even also be irritability and some physical symptoms. Most importantly, there could be some suicidal thoughts that could be associated with these episodes as well. Depression is one of the most common psychiatric issues that we see in and around us. It can be caused by a wide variety. On the right-hand side is just a way of thinking about how multifaceted it is. We don't have a clear specific area that is affected. There can be an impact on genetics, the various chemicals and neurotransmitters in the brain, the different modulatory proteins in the brain. There's, of course, the impact of stress and inflammation. And I just wanted to kind of put it out there in terms of how to think about depression. In terms of the prevalence, about almost 10% of Americans about 12 years would have experienced an episode of major depression in the past year. And it is increasingly common with young adults, particularly ages 18 to 25. And this is also the adolescent and the young adult population is also where we're seeing most rapidly an increase in the prevalence of depression. However, there hasn't been a concomitant increase in help seeking. And so that remains low across populations. It is an illness that, again, carries a lot of impact. It can be associated with early termination of education, affects various forms of social functioning, including marriage, probability of divorce, household incomes, as well as greater impact on physical health as well. So what are the current treatments of depression? Just to think about all the various areas that are ultimately leading to depression, the specific area where depression is really focused on and has been traditionally over the past few years or decades has been the neurotransmitters. The neurotransmitters that we're talking about include serotonin, noradrenaline, and this is what has been targeted most commonly by medications like the serotonin receptor inhibitors such as Prozac, Paxil, or the serotonin and norepinephrine inhibitors, and those are the medications such as Effexor or Cymbalta. You might have heard of some of these, but this is also where the ketamine is also having an effect, and potentially also ECT. However, ketamine and ECT are also affecting neurotrophins or the neuromodulatory proteins, which are leading to enhanced connectivity and neuroplasticity in the brain. And that's also the area where TMS is working. Of course, TMS and DBS are also working at the structural connectivity and activity levels. So we've talked about this a few times, but treatment-resistant depression does not have a clear definition at this time, but for most research purposes, it is defined as failure to achieve a response or complete resolution of symptoms after 2 or more adequate trials of antidepressants. Antidepressants do take a while to have an impact, and so an adequate duration of an antidepressant use is defined as at least 6 to 8 weeks at an adequate dose for that particular medication. So at this time, as we mentioned earlier, medications aren't leading to response or remission for quite a few people with depression. And that's why there is an increasing need for interventional modalities. And this is just putting together the response rates to the different, or the remission rates to the different modalities. TMS, again, we discussed anywhere between 15 to 30%. Ketamine remission rates, which is resolution of all of the symptoms of depression, is anywhere between 40 to 50%, and ECT still remains the most effective treatment, specifically depression with psychotic features. with the remission rate of about 75 to 85%. So in terms of depression, there's a wide variety of treatments that we have available in addition to medication, most importantly being TMS, ketamine, and ECT, and there's a lot of other treatments that are also in development. Just quickly wanted to review some of the other indications as well. Dr. Ostroff mentioned that schizophrenia is not one of the clear indications for ECT at this time. However, it is also a very prevalent disorder. And it is a disorder that leads to a lot of impact on patients' lives. Patients with schizophrenia are 2 to 3 times more likely to pass away earlier than the general population, often due to the physical illnesses that come up, and also have a higher rate of suicide. What are the symptoms of schizophrenia? These could be longer term issues. We define them as either like positive or negative symptoms based on the activity of or the presentation of the various symptoms. The general positive symptoms could be when the patient or when people are having symptoms of delusions, believing something that is not real to be real, hearing things or seeing things that other people aren't hearing or seeing, or having profound disorganization of speech. The negative symptoms are generally a flattening of affect, reduced speech. There is a lack of initiative or an apathy, and there is that can affect their lives. It also leads to a lot of significant disability overall, and is one of the top 15 causes of disability worldwide. In terms of our interventional modalities, what we can help with is by the use of ECT for schizophrenia. At this time, that's the only modality that is helpful for schizophrenia. We do use it along with medications to treat the symptoms of schizophrenia that I just mentioned. Those medications are called antipsychotic medications. One of the most potent antipsychotic medications often used after the trials of other medications have not been successful is clozapine. And that is a medication that works very well when we try to augment its effect with use of ECT, and can lead to very great response rates of up to 50% in patients who are using clozapine along with ECT. And these effects are primarily on the positive symptoms of schizophrenia. Another disorder that we can potentially help with interventional modalities is obsessive compulsive disorder. Obsessive compulsive disorder is a disorder where you have intrusive, recurrent thoughts that are very disturbing to folks having these thoughts. They try to stop them, but they're unable to resist them, and they continue to happen. Sometimes this is also followed by certain actions that people might do to relieve the anxiety caused by these thoughts, and those are called compulsions. Obsessive compulsive disorder is basically caused by inherent difficulty with the connectivity of some of the deeper brain structures with some of the prefrontal cortex areas. So it has a specific pathway. That is more clear than other psychiatric conditions. With that, OCD can be helped specifically by targeting those connections and those deeper structures in the brain by the use of TMS or transcranial magnetic stimulation, and also by the use, if TMS is not effective, along with medication, by the use of deep brain stimulation, where the probes are particularly implanted to affect the connections between the deeper brain structures in the internal capsule to the prefrontal areas. Another illness is catatonia, which is basically a symptom complex that has been noted or described in psychiatry for a very long time. And that is basically can happen with any illness. It could happen in patients who have depression, bipolar disorder, OCD, or schizophrenia. And it is seen quite commonly, specifically in psychiatric or medical hospitals. What does it present with? Quite a wide variety of symptoms, but basically there are times when patients are not responsive, they might be mute, they might not respond to any of the examiner's manipulations, they might actually maintain certain postures that won't be possible for us to maintain. They will also respond abnormally to whenever their limbs are repositioned, and there might be some agitation or repetition of the words or phrases of the examiner or the movements of the examiner. This can be a very difficult time for these patients, almost as if they're frozen in fear. That's part of the underlying pathology of what's going on, simplistically put. It's most commonly treated with benzodiazepines or lorazepam. Actually, most people, if you take something like a benzodiazepine, such as lorazepam, there might be some sedation. But in these patients, they actually have this response of almost waking up from these stupor states that they had been in. ECT ultimately is actually the definitive treatment for catatonia, even if the patients did not respond to lorazepam. Catatonia is what we can think of a toxic state of the brain, and we want it to resolve as quickly as possible. So in our experience in Yale New Haven particularly, we did have quite a large percentage of patients treated with ECT who ultimately did very well. Another area to kind of focus on is that because these patients might be very stuporous, not mobile, can lead to a lot of medical complications and issues for these patients. So again, it makes it very important for us to treat them as soon as possible. So that was just a quick overview. Now I'm going to hand it over to Dr. Ostroff again to review our service.
Thanks. A little bit about the Yale Interventional Psychiatric Service, and then I will throw it open to questions. Go ahead. So what we do at this service is a complex evaluation. We've become the hub, and our first large satellite is going to be at Greenwich Hospital. The complex evaluation can be outpatient or inpatient psychiatric evaluation, a medical evaluation. We do psychometric testing, looking at mood and cognition scales. And then we triage and do informed consent depending on whether the individual, what modality the individual might benefit from. About 20% of the patients who are referred to us don't need one of the modalities. They need an adjustment of their medication. So, and we're happy to make those recommendations as well. These referrals are going to come in through Yale New Haven, and depending on where the individual lives or prefers, they would get treated in Greenwich or Yale New Haven. The doctors at Greenwich Hospital and the doctors at Yale New Haven work as a team, so it would be possible to have a doctor at Greenwich do an evaluation for a patient who lives in West Haven and gets treated at Yale, and we've just in the process of opening up this system in the next week. The modalities are obvious. There's neuromodulation, which we've talked about. TMS is at Yale New Haven, not at Greenwich Hospital. ECT will be in both locations. Pharmaceutical interventions now clinically are ketamine and esketamine at both sites. We have active clinical trials, meaning new drugs and new ways of administering drugs at Yale New Haven, and expect them to be mirrored eventually at Greenwich Hospital. We have like what I think we like to call a tumor board model, where we discuss complex cases that need complex interventions, that it's a confidential multidisciplinary forum where we discuss these cases to make recommendations. And we have input from multiple specialties, including neurology, psychiatry, and anesthesiology. And the reason I like to refer to it as a tumor board model is that it comes from oncology, and I think it highlights the seriousness of these illnesses that people are suffering from. We do what is increasingly called measurement-based care, where we use rating scales that are both objective and administered by a rater, or subjective, and they're self-reports filled out by patients. With depression in particular, we do both subjective and objective evaluations. We do these before the treatment starts, and we do these scales at points of change depending on the modality where we might do something different or adjust it. And we don't use them to make the decision, but we use the scales to inform the decision that ultimately the physician is going to make the decision based on their interview and the use of the scales. We use the Montreal Cognitive Assessment, otherwise known as the MOCA, for cognitive testing, which we do periodically throughout the course of treatment. The clinical administered dissociative scale is something that's done for ketamine. I tell patients that you might have side effects during the actual treatment where you have an out-of-body experience. Some people find it quite enjoyable. Some people find it very disconcerting, but people do not leave our clinic until that's resolved. And we use the CADs as one method of assuring that any symptom they go home with, they came in with, and typically these scales are 0 at the time of discharge from our clinic. The brief psychiatric rating scale is something we use a subscale of to measure psychotic symptoms, and the Bush-Francis catatonia scale is the standard for measuring the degree of catatonic symptoms, and we do that again periodically throughout the treatment of someone suffering from catatonia. This is what our treatment room looks like at Yale New Haven. One of the 2 treatment rooms looks like at Yale New Haven. I don't have one of Bridgeport to share yet. I don't know if Muniza does or not. But this is a typical set of treatment bays where patients are getting treated. The ECT service at Yale New Haven is Monday, Wednesday, and Friday. And the ketamine S-ketamine service is Monday through Saturday. TMS is Monday through Friday. So it's a very busy service. Greenwich will start with Monday, Wednesday, Friday for ECT and ketamine to begin with. We have a monthly case conference followed by a business meeting that people from both hospitals will attend. At Yale New Haven, we have 6 attending psychiatrists, a chief resident, actually now 7 ECT nurses, 3 mental health technicians, 1 nurse practitioner, and we work with a team of anesthesiologists when we're doing ECT at Yale New Haven. So I'm assuming that these are pictures that people recognize at Greenwich Hospital. Do you want to say anything specific about the Greenwich Hospital service?
Yeah, absolutely. So we are starting our interventional service at Greenwich again with basically the idea that it's a satellite of the Yale New Haven service. So it is still the Yale Interventional Psychiatry service, and there is a lot of overlap and support from New Haven. We are going to be providing ECT services Monday, Wednesday, and Friday, along with ketamine and S-ketamine. They will be conducted at Greenwich Hospital in the medical ambulatory area. We will be working with our nurse practitioner, myself, and other psychiatry attendings, along with a wonderful staff of nurses who have been particularly trained for these modalities as well, and mirror all of the services that are available in New Haven to provide just as good a level of service to anyone who's coming to Greenwich.
I think I want to make one point that we didn't cover, which is the notion of neuroplasticity. And it's a term we use a lot. And what that means is that there used to be the notion that the brain was fully formed and set by age 25 and didn't change after that. There was also the notion that the brain was an organ that communicated, that either sent signals out to the world or received signals in from the world. And what's been obvious in the last 2 decades is the brain regions communicate with each other. And when we talk about neuroplasticity, what we're talking about is treatments that affect changes in the brain and make it more open to being reformed and to process information differently And most of us in interventional, even though we're doing significant psychiatric interventions, believe that psychotherapy is an ideal treatment to partner with these treatments, because if you're creating a situation where the brain is plastic and changing, that's the ideal time to to introduce new ways of thinking about things and new ways of processing information. So the one large study we have right now is the ENDOR study for ketamine, looking at whether cognitive behavioral therapy will make a difference in the outcome of patients receiving ketamine treatment. And we published several papers showing that cognitive behavioral therapy increases the response to ECT as well as to ketamine. So we're fairly bullish about the use of psychotherapy along with these treatments. I think we've probably told you more than you want to know about this subject, but
Very nice, very nice. Well, thank you very much, both of you. You've certainly given us a lot to think about, some great information. So at this point, we will take some questions from the audience. Anybody have any chat questions? Just enter them in chat and direct them towards questions for NAMI speakers, and we'll take it from there.
Great. I'm going to be moving back and forth between the chat and some other questions we have here. So this won't be in any particular logical order as I try to get through the questions the most we can. So thank you for staying on for questions. We had one very early on. Somebody asked, if a person has a history of substance abuse issues, is ketamine therapy inadvisable?
Oh, I can weigh in there. It depends on how recent they are, whether they're actively getting treated for the substance abuse problem. There's some data that shows that people with depression and a past history of alcoholism might be great candidates for ketamine. What we worry about with ketamine is that it can be a potential drug of abuse, so we're very careful about people who've had an abuse history. We also want people to be to be able to be abstinent or in remission. I think the real problem for us is the struggle with people using cannabis, because I don't think we've talked to anybody in America who doesn't use cannabis at this point. At least that's the way it seems to us. So it's really hard when I think there's a big difference. The analogy I use is that if we had a patient who said they had a glass of wine on dinner on Saturday night, we wouldn't worry about it. But if they were having 3 drinks every night, we'd worry about it. Mm-hmm. And so I think there's variation that can be quite challenging with the use of substances.
Got it. Are there cognitive problems with ketamine? Sort of in the long range, you talked about disassociation, but is there a longer issue in memory?
Probably not. There was one signal that there may be some. Muniza, do you remember it was
Sure.
It was
Yeah,
processing?
Yeah, so the concern with cognitive issues with ketamine primarily comes again with use in excess and very high frequency. And so the long-term concerns about cognitive impact are basically coming from the abuse data. We do have, a long-term follow-up with a lot of patients, and also longer-term studies or data coming out from patients who've been doing ketamine in a therapeutic setting for depression for a while. They don't seem to have the similar issues, but they're in the abuse data. What we did find was there was issues with attention and processing speeds were some things that were impacted with the use of medication in excess. So it's hard to correlate that with the therapeutic use of sub-anesthetic or lower dose ketamine at much lower frequency and much more spread out over time.
Thank you. We also had a question, particularly in the IV form of ketamine, is there such a thing as having a bad trip?
I'm not sure how you define a bad trip.
Mhm.
Both with IV and intranasal, we see people with significant dissociative experiences. It's rare. It can be psychotomimetic, so people will hallucinate, see God, see the devil. What's been interesting, the clinical lore is that you need to have that kind of dissociative experience to have an antidepressant effect. It's clearly not true that you don't need to have those kind of dissociative symptoms to have an antidepressant effect. And the data doesn't support that. We've seen people, and it's actually rare where we have to make an intervention. We see people maybe once every couple of months, and we're doing 80 treatments a week. So we'll see somebody have what seems to be a bad trip where they're yelling or crying. What's been interesting to me is the subjective experience is often very different than the way it looks. So somebody appears to have a bad trip. It dissipates after 20 minutes and they feel great. And their memory of it was that it was quite pleasant. We have other people who have very mild dissociative out-of-body experiences who hate it. So the subjective response doesn't seem to jive with what you observe clinically. I think the important thing is these don't endure.
Mhm.
So they really resolve by the time we send people home.
Okay. Somebody has given, I'm going to summarize this a little bit, but they say, my son has been on numerous medications over the years for depression and mood disorders. Nothing has helped with any significance. He's been an inpatient over 9 times, including sometimes at Yale, and done many programs. They're at a loss. Is that someone that could come in and potentially be helped, or you would work with that type of case?
Well, that sounds like our typical kind of case, but we want the referral to come from the treating physician or treating nurse practitioner.
Okay, fair enough. Somebody has asked, what anesthesia is used for ECT treatment?
Go ahead, Muniza.
So if you think about the anesthesia from ECT, you could think of something similar to what you would get during a colonoscopy. We use some medications within the same class as like benzodiazepine. Sometimes it, again, is patient dependent, but our most commonly used medication is Brevitol. Also, basically something like propofol could be used. We sometimes also use ketamine, which is again a commonly used anesthetic agent as well for ECT. So it will depend on the specific patient, but it's something that you could equate to as something you would get during a colonoscopy or endoscopy procedure. And then you would recover for about 30 minutes or so after the procedure and be good to go. The only additional part, of course, is that we do give medications for muscle relaxation during the procedure. So that's also a part of the treatment for us with ACT.
Here's an important one. Are these services covered through Husky D and other insurances?
Yes, except for intravenous ketamine. Intravenous ketamine is what we developed initially and use it as treatment. The studies were all done for FDA approval using the intranasal. So the FDA only approves the intranasal. We do have some contracts with insurance companies for using intravenous ketamine. Almost all of the insurance companies cover, and I say almost all, not all, cover the use of S-ketamine, the intranasal ketamine treatments. And Husky does cover it.
Great. Somebody's asked, after the initial treatments of whatever modality, are there follow-up treatments required? In other words, do people have to receive additional treatments 1 year, 2 years after some of these initial treatment periods?
Yeah, I can take the first attempt to answer that. It depends on the condition that you're treating. Major depressive disorder, particularly difficult to treat depression, is a recurring disorder.
Mhm.
If you give someone Prozac and they get well and stop the Prozac immediately, there's about a 60% relapse rate in the first 6 to 12 months. If you give somebody ketamine, it looks better than that in terms of the relapse rate. But what we're finding with ketamine is that people need some kind of maintenance treatment. It's not unusual for us to do 2 treatments a week for 4 weeks and then 1 treatment a week for 4 weeks. And it's the only thing that's ever worked for somebody. And we spread it out and use a maintenance kind of treatment where they come every 2 weeks and then every 3 weeks and then every 4 weeks. We have some patients coming in every 6 weeks for a single treatment. But it's hard to predict relapse with a recurrent disorder. Same thing with ECT when it's the only treatment that's worked for depression, and depending on the illness of the patient, we may continue it for 6 to 12 months, but that's usually once a month as opposed to once every 3 weeks where we're continuing it. TMS is a relatively new modality, so we don't have good longitudinal data for relapse. We've seen people have a robust response and then relapse 2 or 3 years later, and we just don't know. So people typically are not doing a maintenance form of TMS now, but they are increasingly doing what I would call a continuation phase treatment of ketamine and ECT.
Mhm. Okay. Somebody has asked a few questions about TMS here, such as, does it hurt when you're doing it or afterwards? I guess they might mean headaches or actual, do you feel the
Right.
magnets?
So again, the treatment basically involves having the conductor arm applied to your scalp. You have a specific hat on, so it's not directly touching your skin, but there might be some tingling or some other forms of sensations. Some people might find that difficult to tolerate, but these are not very common. We can always work with the use of any particular analgesics on the skin to help with that. There might be some headaches that could happen after the treatment, and again, are some things that analgesics could help with. Again, those are the most common symptoms, but do not occur very frequently. If anything, it's actually the machine does have a very loud voice, a clicking sound. So that actually is the most significant part. And we do give patients earplugs to deal with the noise of the machine. But other symptoms are less common and remains the one with the least side effects. But those, when they do happen, we can definitely address and treat.
Somebody has written in here, about ECT, I'm really concerned about the memory loss. How broad is it? And will I lose more memory if I do more ECT?
Yeah, it's much better than it was 20 or 30 years ago with the new devices, but it's still an issue. What's therapeutic about ECT is you're inducing a generalized grand mal seizure that lasts about 30 seconds. When you do that, it's very common to lose what we call short-term memory or immediate memory, which is the hour before and the hour after treatment. So I tell people that about 95% of our patients come in from home. Very, very few are actually hospitalized. And I tell patients they may forget the conversation they had with that their husband had with them on their way into the treatment, and they may not remember instructions immediately after. So we try to respect that for people. It's a side effect, and it happens about 10% of the time. It's actually a fairly common side effect. It also leads to a subjective sense when you can't remember a conversation you had in the car that you've had a memory problem. So there have been studies that show that the subjective sense of memory loss is much greater than the actual objective loss. There have been studies that show you can lose isolated bits of autobiographical memory that go back 6 months prior to the treatment, which is that you don't remember going to somebody's graduation party or here going to a concert or something that happened 4 months before. And the confounding variable there is that depression itself can cause what we call pseudo dementia of depression, where you can't recall, form new memories, or attend very well. So it's hard to know how much of that is ECT induced versus the severity of the depression. I think that the best data is that if you measure memory functioning prior to ECT and you measure it 2 months after somebody's had a response, it's actually better 2 months after somebody's had a response. So I use that 2 months period as when it would clear up. If people are getting maintenance ECT where they come in once a month, it's almost never a problem.
Right. Somebody has asked here, oh, I have to move that. Moving chat around is a finicky thing on this computer. Sorry about that. How would I begin the process to do these treatments in Greenwich Hospital?
Yes, that's a great question. So our basic process remains the same. So you'll be contacting our main line, which is based in New Haven, for, again, the referral from your provider. You can definitely share this phone number with your provider and have them contact our patient navigating staff, and they can get you started on the process. So I'll just, is it
Put it in
okay
the
if I
chat.
share the number in the chat, or?
Yeah,
Yeah.
Okay.
put the number in the chat, please. That's great. To everyone, yeah. And somebody has asked, must someone have been on several treatments before applying for your services?
No, it depends on what service and what we're treating.
Okay.
For depression, typically, without suicidal ideation, just chronic depression, typically we see people who've failed several medications. Every once in a while, we'll see someone who can't tolerate medication for a variety of reasons, and we'll evaluate them early. The indication for S-ketamine, the nasal spray, is that you have to be on an antidepressant in order to respond to treatment. So sometimes we'll get referred patients who've been tired of being on antidepressants and nothing has worked, and there might be a good reason to start a new one. If there's not a good reason, we try to get it approved anyway, but it becomes I don't want to get started on insurance companies, but it can become an insurance issue if you're not following the way the FDA approved it.
Makes
It's a little
sense.
easier with ECT or racemic ketamine, intravenous ketamine, because we don't have to worry about the FDA approval for the insurance companies we work with.
We have a question here about co-occurring conditions. So if someone is in methadone treatment, are they blocked from trying ketamine and S-ketamine treatments?
No.
Okay.
No, we believe in harm reduction, and sometimes what becomes a vexing issue from a clinical standpoint is differentiating between whether the depression is driving the substance abuse or the substance abuse has been driving the depression. But somebody's stable on methadone, it's not a contraindication.
Right. Somebody had also asked, you mentioned in the presentation that ECT is safe with pregnancy, but why do you do a pregnancy test before those treatments?
Oh, it's a good question. Because we want to know. It's a safe treatment, but we want to be able to warn of the risks of the risk is the risk of exposing the fetus to anesthesia, which is a lot less than exposing the fetus to chronic drugs, and we think that we should know that. And we've never had a problem, but we like to make sure that we're informed.
That's
And with
understandable.
ketamine, there's no data.
Okay.
ECT, the data is pretty good. With ketamine, there is no data as to the safety of ketamine in pregnancy.
And finally, maybe this will be the last question. I think it's about the last I've read on here. Can I drive myself to and from each of these treatments at your facilities?
No. You can drive yourself to, you can't drive yourself from ketamine or ECT. You cannot drive on the day of non-negotiable. You can't drive on the day that you get ketamine or ECT. We have had people drive themselves in, and then there's significant other drives them home. But you can't drive yourself in. That's one of the advantages of TMS, is you can drive in and drive home.
Okay. Well, that's wonderful. That we've certainly learned a lot about all three of these treatments and many others. It's incredible.
So is that the end of our Q&A, Susie?
I think so.
I think so. Wow. Well, this was simply wonderful. I'd like to.
Thanks for having us, by the way.
Oh,
you.
well, thanks for coming. We really appreciate all this great information and you spending the evening with us and sharing all your great experience and professionalism. I'm sure we'll get some follow-up. So appreciate you being here tonight. Thank you for everybody for attending. And we've recorded this, so it'll be on our website soon. Thanks again, everyone.
Good
you.
night.